This conference will now be recorded.
Yes, welcome. So we will start with the OSCE sector. Dr. Asma, are you there? Okay. Dr. Zahida, first station for you, second station for Dr. Fariha. So you have 2 minutes. You can read this patient information and then we will start talking about it. Hello. Okay, Dr. Friha, I think you can take that station because I didn't hear Dr. Zahida.
Okay.
So
This
here is
one
the
is the short case. These are the short cases.
right. Yeah. This is
Hello?
Yeah, Dr.
okay.
Saida
Dr.
came.
Zahida is there. Okay, Dr. Zahida is here. Okay, sorry. So Dr. Zahida, first station is for you. Then Dr. Fariha will do the next one.
Okay.
So we are doing this circuit. So there are going to be short cases.
Okay.
So your time starts now. After 2 minutes, we'll talk about it.
Okay.
This conference will now be recorded.
Okay, so can you please tell me
Yeah.
about this patient?
Yeah, the patient Mrs. Martha Gray with a BMI of about 32. She has a complaint of urgency and frequency, and she's felt of wetting herself, and she's she, yeah. So in this, I would like to ask a few more history from the patient, Mrs. Martha, about what is the frequency of her this. Does she have any other complaints other than this, like leak on coughing or sneezing? She has already mentioned to me that she's got urgency and frequency, whether it is associated with burning micturition. And she has also said that she's feeling a lump in the vagina. Then I would like to ask her whether she noticed any blood in her urine, and does she is suffering from any chronic cough or constipation. And also would like to ask about her medical conditions like diabetes, uh, any respiratory diseases, and would like to know her menopausal status as well, because the age of the patient I think is not mentioned here, whether she's attained her menopause or no. Then her lifestyle, some more, what support she has at home, and does she smoke, or is she taking alcohol? A little more history about her lifestyle. Then and this symptoms, yes, it is seen that it's been affecting her quality of life also. So this is about the history of the patient uh, mm, that I would like to take. Then about the investigations, yes, the BMI is taken. I would also like to get her blood pressures checked and get her routine investigations, like the midstream urine sample. Then would also like to give her a bladder diary and ask her to note down what she drinks and how many what all she takes, and how much fluids does she have to void in more than one time during the night, or and how many times during the day, whether it is more than 8 times, to maintain this diary for about 3 days. And this is about the routine investigations. Then would all and the special investigations, I would like to also get her this sorry general physical examination also done, abdominal examination, see if there's any scar or any lump, palpation, just any swelling on the abdomen. And then vaginal examination, speculum examination. There's a moderate cystourethroseal, but other than that, I'd like to know if there's any descent of the cervix or anything like that. Then also get a urodynamic test, uroflowmetry and cystometry done in her case to identify the type of incontinence that is associated with this. And that's about the relevant investigations. And coming to the management options, yes, one is the first thing is lifestyle modification. Would like to advise her on about her control of her weight. Would get a professional prepare a diet chart, the exercise schedule, and this to give an idea. Then after that, to restrict the fluid intake and diuretic fluids like coffee, or if she's on alcohol, to stop it. These are the general measures that in case there's an infection which midstream urine sample shows E. coli, so would like to also give a course of antibiotics to her. And then after that, my management will depend upon the level of the prolapse and mm, mm, and we'd also advise her about the pelvic floor exercises as well by a trained physiotherapist, and how to do it in order these symptoms be under control. And then and mm, urgency and frequency she has, so it's like an over likely to be a overactive bladder, so would also like to go with the treatment of antimuscarinics for her based on the this, and tell her that it may improve her symptoms for about over a period of 4 weeks, and she needs to be on it. But before advising that, I would like to rule out if she is having any complications or any contraindications to it, like glaucoma or GI problems, or uh, so these things, any hypertension. Uh, and hello.
Yes, I'm listening.
Yeah.
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 So what options you will offer her for management?
First is, yes, the lifestyle modifications initially, because I know that she's on a higher side of a BMI of 32. First thing that, and then treat her urinary infections with a course of antibiotics. Give her a bladder diary for this bladder training. For would like to also advise about the bladder training for 6 weeks. Then pelvic floor exercises for 3 months, and then after that would like to go for the medical line of management with the drugs. We have the first line like oxybutynin, and
Yeah.
before ruling out the ruling out any contraindications to these medications, then I would like to go ahead with those line of treatment, and tell her it takes about 4 weeks for her to see the effect, and about 60% improvement can be with this. In case these fails, then I would like to refer her to the urogynecologist for further management.
Okay. So thank you very
So
much. Dr. Fariha, will you like to comment on what he said?
Yeah, Dr. Saida did very good, and she mentioned everything. And just I think I don't remember if she mentioned that we have to just rule out the red flag like blood in urine, if she has the one question.
Yeah.
And otherwise, she did very well. Yeah.
Yeah. That's fine. Okay. Thank you. So let's go to the next station. Okay. Okay. So you have to give a short talk on PCOS. What happens to the patient? What problems can be there, and how you can fix them. You will take 2 minutes and then we'll talk.
This
and they
conference
can
will now be
present with
recorded.
infertility or subfertility, and sometimes they present with acne and facial hair growth, and sometimes they can have loss of hair as well, and also they present with weight gain, and sometimes they can have symptoms like they can have some depression or mood swings, and they can
So,
have also a long-term risk, like they can have sometimes they develop diabetes, cardiovascular disease, or sleep apnea in the long term.
okay. So, how do you diagnose PCOS?
Basically, the polycystic ovaries can be present on ultrasound, but to diagnose polycystic ovarian syndrome, we have a Rotterdam criteria in which we have to have at least there should be two of the three criteria which should be met. There can be polycystic ovaries on the ultrasound, and polycystic ovaries means that the ovaries, they contain multiple follicles, and they are like 5 to 10 in size, and they are like a like a necklace, they are surrounding the ovary, and the stroma is dense and the ovary size is large, and there can be 12 or more peripheral follicles, and also these patients, they should have either clinical or biochemical evidence of hyperandrogenism, or they can have a menstrual problem, like they can have anovulation. So at least two of the three criteria should be met to diagnose polycystic, and then we should, it is a diagnosis of exclusion also, because we have to rule out other causes of hyperandrogenism, like we have to rule out congenital adrenal hyperplasia, Cushing syndrome, hyperprolactinemia, and then we can come to the final diagnosis of polycystic ovaries.
Okay.
And for the so we will do some tests when a patient comes. We will take the clinical picture into account, and then we will do her hormonal profile, which will include FSH, LH, sex hormone binding globulin, and prolactin levels, and testosterone, and thyroid function test. So if FSH LH ratio is reversed, there is a like for FSH the cutoff is 10, and for LH the cutoff is also like if it is higher than 10 and FSH is low, the ratio is reversed. That is one of the indicator. Usually it is not taken into account nowadays, but it indicates that there is hormonal imbalance. Then testosterone may be a bit higher, like it is not very high, but it can be a bit higher. And the prolactin also can be a little bit higher in the polycystic ovaries. Hello.
Yeah. So these are
Yeah,
the
and
ways.
sex hormone binding globulin is low usually in cases of polycystic ovaries.
Yeah. That will be low and testosterone level should be high. So, what do you think are the important aspects of PCO that you need to discuss with the woman at this stage?
Yeah, we have to tell the patients that polycystic ovarian syndrome is a common condition, but if we will advise them lifestyle modification. If it is like they keep their weight normal and they remain physically active, then the complications can be avoided. In the long term, polycystic ovaries, they can lead to diabetes, usually type 2 diabetes, and hypertension, and cardiovascular problem, and sleep apnea. And then they can also because there is endometrial thickening because of oligomenorrhea, so they are also predisposed to the increased risk of endometrial cancer. So we have to give them withdrawal bleeds. We can give them like every 2 to 3 months, we can give them progestogens, so that they can have regular cycles every 2 to 3 months, and then prevent the risk of endometrial cancer. And if they have high BMI, like if it is more than 35 or with any comorbidities, and or more than 40, then we sometimes offer them to join the slimming clinics and do regular exercise. If they are not able to control, then we can offer them weight reducing medicines, and also we can refer them to the bariatric surgery. And these patients, they need to test their glucose tolerance test. Rule of diabetes, every year they have to do the test.
Okay, so can people with low BMI, women with low BMI, they can also have PCOS?
Yes, the women with low BMI also can have PCOS.
Okay. So if this woman wants treatment for her irregular cycles, so what will you like to give her?
First of all, we will advise her lifestyle modification, like we will tell her to have regular exercise at least 30 minutes, 3 times per week, and to have a healthy diet, a healthy balanced diet, and to control the weight. If the first line does not work, then we can offer her hormonal treatment for regularity. If she does not desire fertility, then we can offer her hormonal pills to regulate her menstrual cycles. That can be in the form of combined oral contraceptive pill or progestogens. And this combined oral contraceptive pills usually we recommend with the low, the one with the which contain progesterone with the low androgenic index. And like we can offer them Yasmin or Yaz. They can take it at least for 3 to 6 months to regulate the menstrual cycles.
Okay.
And if she is desirous of fertility and she has a risk factor for diabetes, then we can start them on metformin as well. These are the insulin sensitizing agents which can help them with ovulation. And if ovulation is treated, then they can have regular menstrual cycles.
Okay. So what strategies would you recommend to this patient for the reduction of long-term consequences of PCOS?
We can offer them lifestyle advice, weight reduction, dietitian referral, a healthy balanced diet, and this insulin sensitizing agents metformin can be given to for menstrual irregularity and to improve ovulation. And then we can also give them weight reducing drugs like orlistat, which can help weight loss in women with high BMI, and that may also improve insulin sensitivity. And still, if they are not controlled, then we can offer them bariatric surgery as well.
Yeah, that's great. Okay, so is there a place of surgery in the management of PCOS?
Usually in polycystic ovaries with low BMI, they are recommending laparoscopic ovarian drilling, which is done, which is a surgery which can done through keyhole surgery or open surgery. And they are giving basically, they are doing electrocautery to the ovaries at 4 points, 40-degree watt, and for 40 seconds. And the evidence has shown that this can improve the ovulation and reduce the androgen levels for at least 20 years. And that can help maintain regular menstrual cycles, and they can achieve fertility as well. But there is a we have to explain the risk to the women that sometimes there is no risk of multiple pregnancy or ovarian hyperstimulation, but there can be risk of adhesions, and sometimes there is a very rare risk of premature ovarian failure.
Okay. So how do we do this ovarian drilling?
Basically keyhole surgery or open surgery, and it is done by some skilled surgeons, and they are doing that they are doing electrocautery at 4 points in the ovary in the stroma, and that will be for 40 watt electric current is given, and for 40 seconds at 4 points, and that destroys the stroma. And they say that it corrects the hormonal imbalance and the androgen levels are reduced.
Okay, okay, that's great. Okay. So, PCOS, thank you, Dr. Priya. Still a very popular topic because PCOS is responsible for 85% cases of an ovulation and infertility. So, symptoms you mentioned very well, like infrequent periods, oligomenorrhea, infertility, hyperandrogenism, hirsutism, acne, obesity. Then, for the diagnosis, we have to, this is a diagnosis of exclusion, so exclude thyroid dysfunction, congenital adrenal hyperplasia, hyperprolactinemia, adrenal tumors, Cushing syndrome, and we will use Rotterdam's criteria for the diagnosis. At least two of the symptoms should be, features should be positive. Ultrasound should show either 12 or more peripheral follicles or increased volume, which should be more than 10 cubic centimeter. evidence of this biochemical evidence of hyperandrogenism and oligo or anomination. Regarding the test, we have to do thyroid function test. If patient shows symptoms, serum prolactin, free androgen index. This is the most predictive of the test. And how we do that? We do this by taking total not free testosterone, total testosterone divided by sex hormone binding globulin into 100. And if total testosterone is more than 5 nanomole or 17 hydroxyprogesterone, it should be measured and androgens feeding tumors should be excluded. So if there are suspicions of Cushing, then this should be investigated according to the local protocols. So what advice should be given to this woman? Tell her about the long-term risk of type 2 diabetes and sleep apnea risk is increased if BMI is higher, increased risk of cardiovascular disease. And if she's having sleep apnea, her risk of having MI will increase. So implications if she wants to become pregnant, she has
Pregnant,
fertility
yeah.
aspirations, then we should say that she needs to be screened for GDM at less than 20 weeks gestation, more than 20 weeks gestation, and should be managed accordingly. Other problems related to the BMI like hypertensive and high chance of operative delivery or abnormalities in the baby. So what the abnormalities in the baby will not be due to the PCOS because of the maternal obesity, neural tube defect, IUGR. So if she does have PCOS, what risk might she have for cancer in future? So increased risk of endometrial hyperplasia and carcinoma. So regular withdrawal bleeds are recommended. So the strategies to improve her long-term health consequences of PCOS, advise exercise and weight control. She can benefit from insulin sensitizing agents like metformin, and weight reduction drugs may be helpful in reducing insulin resistance, but they will have their side effects. So still first line is exercise and weight control. Is there any place for surgery in patients with PCOS? Yes, ovarian drilling. You will make touch 4 points with the electrocorticoid for 2 seconds. Signs are that it will cause destruction of the ovarian tissue and adhesion formation can be there, but their chance is very low. And if the patients, now you should remember they change this one that if the BMI is 40, she will go for bariatric surgery. And if her BMI is 35, but she has comorbid conditions or family history of diabetes hypertension, then at BMI 35, we are going to offer her bariatric surgery.
Surgery.
Thank you very much. Dr. Zahida, Dr. Asma, you want to add anything, please? Okay.
What about metformin, Dr. Aisha? This first guideline for RCOG, it said that metformin should be given. Then in the next guideline they revised, they said that if only type 2 diabetes or risk
Yeah.
factors for diabetes, then metformin
Yeah.
should be given.
So again, before why we were giving metformin, this is insulin sensitizing agent, and we usually they will give metformin if the BMI is 30 or higher. Okay, so still the same. This is only insulin sensitizing agent, and if the patient's BMI is higher, you should give her metformin because this is recommended by ACOG also. So we are going to give metformin if your patient is obese. Because the problem is that RCOG people they changed their green top guideline, but that was also changed in 2015, already
Mm.
4 year old, right? But they didn't make any changes to the guideline on infertility, and that was published in 2013. Now they are going to change that, but still, if they don't change, we are going to stick to the same thing. Because PCOS patient, you are going to see if he is having infertility or if she is having irregular cycle. So we need to give her insulin sensitizing agents not to decrease her weight. The purpose is to decrease the level of LH, because unless the level of LH is suppressed, it will not rise at the time of this ovulation. So if you will give metformin, then insulin can enter the ovaries and decrease the level of LH, and then because in the PCOS patients, LH level is maintained at a certain basal level. It will never show any spike. And you know that this surge should be there to trigger ovulation. That is the basic pathology. So even if the LH level is very high, still there will be no spike because the basal level is very high. So we are using insulin sensitizing agent so that insulin will go there, inhibit LH, bring it down to the normal level, and then due to as in concert with other hormonal changes, it should rise before ovulation. So, and if your patient has other problems like he has some renal problem, or she's likely to develop metabolic alkalosis, like she has a history of chronic renal disease, then you should not give. Otherwise, you can give it safely. It has not been associated with any severe adverse effects. Still can be given. For weight reduction, you should remember that with metformin, weight reduction is not significant. For that, patient has to stick to the diet control and exercise. Diets with low glycemic index and 120 to 150 minutes of rigorous exercise in 1 week. Those are the points. But metformin, yes, we can still give it to her, even if her symptoms will not improve, but hirsutism, it will decrease. It will, like in 11% of patients, they will find relief for hirsutism. So you can give that because PCOS has many features. Basically, the problem with PCOS is that we don't have any definite treatment. Statistics show that 1 in 3 is going to have that, but if in your common practice, you must have also noticed that more and more patients are coming with PCOS. It can affect all patients, regardless of their BMI or their age group. It is very common, and still our understanding is incomplete. But as far as metformin is concerned, yes, we can always give it to her. That is the point.
And for this menstrual irregularity, then we can offer them this low dose contraceptive pills and the
Yes, yes,
cyproterone acetate and
yeah, yeah. And ethinyl estradiol, you can offer that one.
this eflornithine also they are giving for
Yeah,
hirsutism on the
cephalornithine
face.
they are giving. Actually, if we will talk about the treatment of hirsutism, many things can be given, but the problem with the uh, this last product you mentioned, the problem is that as long as the patient will be using these drugs, there will be no hirsutism. But the moment she will stop using them, she is going to have the same problem again. That is the drawback. So cyproterone acetate, and she will use again. Once she will stop, again she will have the same problem. So if we talk about the definitive treatment, the treatment is laser ablation. If he can afford, and she will need multiple sessions. Otherwise, she should use COCPs, which contain cyproterone acetate. She should use them indefinitely to suppress the hair growth so that the androgens level will be low, or she will have to use the cosmetic methods. Actually, treatment of this hirsutism is very, very difficult. Now with the laser, it is becoming easier, but all other methods are like temporary. Because for how long she can continue taking drugs, it's not easy. And they have their side effects also. So now the new recommendations were that like finasteride and flutamide, they should not be used. So you are left with the options of COCPs, metformin, and this epinephrines, the solutions, and then you can offer the physical methods like shaving, bleaching, waxing, plucking, and then more permanent methods like laser. This is the key. But people and you can use they can use depilatory procedures also, but the results are not permanent. This is the point. So a lot of work is required here to find better drugs because this is a real concern, both for infertility, for hirsutism, for irregular cycles. So, but we have
Thank
to
you.
answer in the light of the evidence. Yeah, yeah. Please go on.
Okay, thank you so much.
No problem at all. Okay. So Dr. Asma is there?
Yes, Doctora, I'm here.
Okay, yeah. Next station is for you.
Okay.
So you will take 2 minutes, then we'll talk about her. Can you see the screen?
Yeah,
Or-
I can see. Yeah.
Okay, that's great. So you will take 2 minutes, then you will talk about her.
This conference will now be recorded.
Yes,
Yes,
you can start,
okay.
please.
Okay, Doctora. I have a patient now. She's currently 29 weeks pregnant and she's known to have a sickle cell disease. The plan of the antenatal care actually it should start from before the pregnancy itself. We should revise the patient condition and her hemoglobin, and we should revise her medications and any medications which are contraindicated in pregnancy. We should stop it, like hydroxyurea. If she's taking it, we should stop. And then once the patient is getting pregnant, then her antenatal care will be in an obstetric unit, and she should come for first the booking a visit. We will do her booking blood, and we should most important to monitor for any infection like urinary tract infection. We will do the urine analysis and midstream urine regularly, and we will do her dating scan at 7 to 8 weeks, and then we will do the anti-scan at 11 to 13 weeks, and we will do anomaly scan at 20 weeks. This patient is currently 29 weeks, and her follow-up it should be almost every 2 weeks. We will monitor her hemoglobin, and we will monitor her if she has any infection. We will do also the gross scan at 32 weeks. If the patient she developed any acute complications like crisis, sickle cell crisis, first we have to identify the cause why she's having the crisis. If the cause of the crisis is infection, then we should promptly treat the infection with antibiotic or dehydration. Then we should admit the patient. First we will give her analgesics. We start with the simple analgesics like paracetamol. We shouldn't give her the non-steroidal anti-inflammatory medicines, and the patient should respond in half an hour. If she didn't respond in half an hour, then we can give her the morphine, and we keep her warm, and we treat any dehydration. We give her normal saline, a half normal saline, and normal saline, and then what else? Treat the infection, and we check the hemoglobin. If the patient is having hemoglobin less than 7, we can consider, or less than 6, we can consider the blood transfusion for her, and we will liaise also with the hematologist to review her. What else? With complication of disease. That's it. We keep her warm, hydrated well. We give her blood if she's anemic. We give her analgesics, and we treat the cause of the crisis. Anything else? Yeah. Okay. Yes. Yes, we will plan for her delivery. Delivery also should be in obstetric unit, and we should also take all the precautions in order not to get the patient into crisis. Also, we will avoid dehydration, avoid pain, avoid cold. and there is no indication for cesarean section. The patient can go for normal delivery. During the delivery, she will have continuous monitoring for the baby, and the cesarean section will be only for obstetric indication. Nothing. The only thing also that we will avoid giving her Bethadine, because Bethadine it's an epileptogenic drug. It can precipitate convulsions for her or crisis. So we will give her, instead we will give her morphine. We can consider also for the analgesia giving her the epidural, and then after the delivery we will do the risk of thromboembolism. Sickle cell itself, it gives score 3, so
Yes.
most probably patient will need to have the heparin 6 weeks after the delivery.
Yes. So, in the sickler, what about the other problems? Can she develop PET? Can she develop GDM?
Yes.
Yes, is a risk factor, so you should comment on them also, okay? Because high risk of developing PET, right? That is the
Yeah.
problem. You should mention all of these problems. So, what can happen to the pregnant fetus? Because till now we have talked only about but what problems she can have.
Sorry, Doctora, again, your voice was interrupted.
Fetal complications. If the mother has sickle cell disease, what can happen to the pregnancy and to the baby?
Yes, babies will be at risk of having IUGR. That's why we have to do the growth scan, serial growth scan from 28 weeks. And then what else? We will also, if her partner also will check if her partner also having sickle cell or not. So baby will have the risk if he sickle cell also, then the baby will be at risk of also having sickle cell himself.
Yeah, actually, thank you very much. But you should just, whenever you're talking about any problem in the mother, you have to address both sides of the story. What will happen to the mother? What will happen to the baby?
Okay.
That is the point, okay? So you should say that high chance of miscarriage, IUGR, preterm labor and delivery, and even IUFT can be there, okay? And then when you're talking that she should get folic acid, how much folic acid? 5 mg.
5.
These are the things. Drugs you are stopping. So when you should stop? Like 12 weeks, 3 months before starting to try for the pregnancy. Then immunizations are very important in cases of sicklers, right? So which immunizations are essential for the sicklers? Which vaccinations are important?
Pneumococcal vaccine. It's for influenza vaccine. It is given yearly. Pneumococcal vaccine will be given every 5 years, and pneumococcal,
Meningococcal.
one more. Meningococcal also
Mhm.
2 yearly, I think. Yes.
I think yearly you will give that one also yearly. And if they will not ask you about the durations, but you should know that you are giving her these key vaccinations against encapsulated bacteria because their spleen will undergo autoinfarction, so they are more likely to get infection from encapsulated bacteria. That is the problem. Okay. So that is the reason. Okay, so this is an important topic. So all of you should read the main points in thalassemia and in sickle.
6%.
That is important. Okay.
And one
So
point, Dr. Aisha, we have to induce them because after 38 weeks, we cannot leave them to be more than 40 weeks because there can be risk to
yes,
the mother and the baby.
yeah, risk for the mother and also risk for the baby. There can be stillbirth, there can be sudden IU. This is the point. So just go over. You don't have to read this full guideline. They have given nice tables in the green top guideline on sickle cell disease. Just go over that one. Just remember the main points, okay? But you need to do it very well because this time Either you will get sickle cell or thalassemia. Okay, so whose turn is now? Dr. Zahida, I think.
Doctora, one question, please. Yani, in such a scenario, when they give us 29 weeks pregnant already, so shall we start from that time, 29 weeks, or we should say from the very beginning of pregnancy?
You will
How
say
should we
that
have?
you will say that you will take a brief history at how things have been throughout this pregnancy, and did she have a dating scan, Down syndrome screening, an anomaly scan, OGTT, because we have to do OGTT in this patient, high risk of developing diabetes because of the damage to the pancreas, or damage to the liver. She can have many other problems. So that's why you will ask her, confirm her that how have been things so far. I will confirm from her, was everything normal till now, and then from this time onwards you will start doing her growth scans, monitoring, and then you will take her to the full review by the has she seen by the hematologist or not. If she has been seen, then you will follow his advice, and then you need to see that does she need VTE prophylaxis, does she need aspirin, and she will take folic acid throughout her pregnancy. So all of these things are important. Okay. So I will add once. Okay, thank you very much. But I want all of you to go over this station because it is important. You can ask.
This one, Dr. Aisha, pneumococcal is every 5 years and influenza is every 1 year.
Every 1 year, and meningococcal.
I think that is every year, I think. And
Yeah, that is also yearly because your patient is basically getting three different vaccinations. Okay, and then you should say that she's also prone to develop pneumonia because pneumococcal is also there. Pneumococcus, meningococcus, and so that's why pneumovax every 5 years. Okay, that is the point. Okay, thank you very much. So Dr. Fariha, I didn't see Dr. Zahida. So Dr. Fariha. Now the same case for you, but your patient has beta thalassemia. Okay, so you will take 2 minutes, plan your answer, and then we'll talk about it. So your time starts now.
This conference will now
Yeah,
be recorded.
start.
hello, I'm Dr. Fariya, one of the exam candidate.
Okay, welcome. So
So yes.
yeah, so if you have a sickler, if you have someone at 29 weeks of gestation with beta thalassemia, how will you plan her antenatal care?
Yeah, this patient is a high risk pregnancy because these patients can have complications, and usually they have risk in the pregnancy, like they can have cardiomyopathy, they can have diabetes, and they can have problem with thyroid, and they can have iron overload. And for the baby, there can be increased risk of fetal growth restriction. So they need regular antenatal visits and also involvement of the multidisciplinary team. They will be booked in the consultant-led unit. So we have to, as she is at 29 weeks of pregnancy, so I will ask her whether she had the pre-pregnancy counseling and whether she has been following regularly, and she has all her regular antenatal visits, which includes the dating scan, the Down syndrome screening, nuchal translucency scan, and the anomaly scan, and whether she has been having a follow-up for the control of diabetes. In these patients, usually we are not doing HbA1c, but we are doing fructosamine concentration, which is done, serum fructosamine, which is done every month in these patients. And then also I will ask her that whether she has undergone checkup for by the specialist for cardiac and renal function, and also whether her partner has been tested also or no, because if the partner is also a carrier, then we have to refer her to the genetic counselor. Then we have to check whether she has her regular antenatal bloods done, which includes a full blood count to check her anemia and platelet count, then blood group and Rh factor, and also red cell antibodies, because these patients usually receive blood transfusion, so there can be a risk of antibodies. And also I will ask whether she had her cardiac MRI and liver peri scan to check for iron overload, And also I have to take her history regarding whether she was taking any iron chelating agent before the pregnancy or no, and what is the present condition, because sometimes if they are they have iron overload, then hematologists may like to start iron chelation after 20 to 24 weeks of pregnancy. There are two types of iron chelating agents, but the desferrioxamine can be given during the pregnancy, but desferapox is not given. It is defripon is contraindicated. So I will check all these things, and I will also ask her that whether she had any problem so far, like any problem with the heart, like palpitation, fainting, dizziness, and how she is doing, how the baby is moving. And then also I will ask about her vaccinations, which include hepatitis B vaccination and influenza and pneumococcal vaccination, and also vaccination against Haemophilus influenzae. And sometimes if they are risk of infection, then they are taking antibiotics also. So I will check drug allergies, and also if she is taking any antibiotics, and also about the vitamin supplements, what she is taking, like folic acid. Usually we are giving them 5 milligrams. And also I will ask her whether she had a regular monthly visits with the multidisciplinary team. And all 20 usually at 28 weeks also they have usually they have to undergo cardiac assessment. So I will check from her notes whether she has undergone or no. And I have to rule out thyroid hypothyroidism also. If she is not if she has any thyroid problem, then she should have thyroid function test. Then also I will ask her whether she is receiving regular blood transfusions, or she is maintaining her hemoglobin. Then as there is a risk of fetal growth restriction, so I will check her growth scans as well, that how the baby is growing, and there is interval growth is normal or no. Then these patients for the plan of delivery, these patients should be delivered in the consultant-led unit.
Yeah.
And also I will assess the risk of venous thrombosis, because these patients sometimes they have splenectomy or they have high platelet count, then they may be taking aspirin or heparin. So I have to check from her that whether she is taking any form of thromboprophylaxis. Then for the delivery, then their delivery should be in the consultant-led unit under the care of multidisciplinary team. And the team should include the obstetrician, the senior midwife, the blood doctor, the hematologist, and the anesthetist. And her blood should be cross-matched, because they usually have red cell antibodies, so there may be problem with cross-matching at the time of labor. And she should be seen by the hematologist to check her iron overload, because sometimes these patients they require this iron chelation therapy, desferrioxamine, during the for the duration of labor. Usually they are given for 24 hours. And she will need continuous electronic fetal monitoring. We can aim for vaginal delivery because thalassemia is not an indication for cesarean section. Only cesarean section will be done for any obstetric indication or fetal distress. And then they are at risk of bleeding, so we have to check their hemoglobin as well. If they are maintaining hemoglobin like 8 to 10 gram per deciliter, then usually they don't require blood transfusion, but blood will be in hand. It will be cross-matched. In case she has any problem, then we can transfuse the blood. And for the for prevention of postpartum hemorrhage, we will do the active management of the third stage of labor. And postpartum, the baby also will be seen by the pediatrician. And then they are at risk of venous thromboembolism postpartum, so we will offer them 10 days low molecular weight heparin for following general delivery and 6 weeks following cesarean section. And we have to ask her that if she plans to breastfeed, then we have to tell the hematology team that whatever iron chelation therapy they will start after the delivery, then it should be the one which is safe for breastfeeding. But usually this desferrioxamine is not orally absorbed, so it is not harmful for the baby.
Yeah, that's correct.
And if she is stable, then she can be discharged with the advice to follow up in the obstetric and the hematology clinic. And also yeah, and we will give her the information leaflet and support groups.
Yeah.
And community midwife can check on her at home as well.
Mm-hmm. Yes,
And
that's
we will
true.
advise her to be physically active and take a healthy diet and healthy lifestyle.
Yeah. So both sicklers and the thalassemics give them TED stockings, mobility, good hydration, and then what else we have to do? These thalassemics. Uh, Once they will go for echocardiography, then they should go for liver scan also. You can say that they should follow for that also because its iron level is also tested. But what you said, that's quite informative and that's helpful also. So it covers everything. Just say that if the patient is anemic, then we can give her top up transfusions. Okay, 2 units can be given. So rest of things are going to be the same.
But
So
usually
here,
we are giving like less than 8, I think. If less than 8
yeah,
gram, then we are giving them
yes, less
transfusion.
than 8 gram. So if indicated, then you will give her top up transfusions. Otherwise, no need. Okay, and they will usually be on a low molecular weight heparin and aspirin because their uh, platelet count tends to be very high, can be up to 600 or even more. So that's important.
But the
So you have
target
mentioned,
hemoglobin for her should be 10, isn't it?
yeah, it should be 10.
Mm.
And then you should say in both cases, like I said before, that you should not forget the negatives, that we will not give them oral iron therapy or parenteral because of the both of them they
Iron
possibly have
overload.
iron overload. That is the point.
Mm.
Okay, so that's all you need to consider when you're caring for the thalassemics or for the sicklers. Thank you very much. So, Dr. Zahida,
Hello?
hello.
Yes.
Okay,
Yes, Dr.
so
Aisha.
next station is for you. So you will take 2 minutes, then we will talk about her.
This
Thanks.
conference will now be recorded.
Hello? Yes.
Hello,
Yeah.
yeah,
What
yes, I
what are
can
the
hear.
what are the indications for vaginal hysterectomy? Yeah, vaginal hysterectomy. Yeah, one commonest indication is the uterine prolapse. Stage two and can be any stages. And then next is the other causes like the abnormal uterine bleeding with failed medical line of management and patient's request. It can be case of adenomyosis. Uh, it can be case of CIN 2, 3, and not requesting for this early stage of CA cervix like stage 1A1. Uh, so these are the indications for vaginal hysterectomy. And what are the steps for vaginal hysterectomy? Yes, it is followed up after a written and informed consent taken from the patient. After discussing with the patient what the procedure involves and what are the and following the enhanced recovery pathway and WHO safety checklist. Uh, uh, we do the vaginal hysterectomy in 3 steps. One is the uterosacral and the cardinal ligament. Second is the uterines, and third is the triple pedicle, which is the tube, ovarian, and the round ligament. So first thing, after painting and draping and patient in lithotomy position, and uh, then bladder needs to be catheterized and cervix needs to be held by a valsalum and pulled down. A gentle traction needs to be applied. And after that, we are going to infiltrate into the cervix lidocaine. It depends upon the individual. This I use about 1 in 50,000 lidocaine and adrenaline to get a perfect plane. I'm going to give a circumcoral incision all around the cervix at the cervicovaginal junction, anteriorly and posteriorly. Then into the stroma of the cervix. Then after that, I'm going to separate the anterior vaginal wall and pull the bladder away. Identify the vesicovaginal fold of peritoneum anteriorly and the pouch of Douglas posteriorly, and open them. Then I'm going to use a curved heavy clamp to my first pedicle, that is the uterosacral ligament. I'm going to clamp it and cut and ligate and transfix it. Now the second will be the uterine, which again I'm going to use a curved heavy clamp and cut and ligate it. And then the third clamp will be to the triple pedicle, which is the tube, ovarian, and the round ligament. And that should be one finger needs to be introduced to follow it as a guide, and then the clamp should be inserted in such a way that the tip is pointing out towards you. Then it should be cut and ligated. After ligating all the pedicles, see for hemostasis and pedicle, and after that then I'm going to close the wall and then do the fixing of the vagina. We know that there is a risk of wall prolapse. I need to fix the vaginal wall, that is the anterior vaginal wall, with the uterosacral ligament. Then after checking for hemostasis, and then this is the steps for vaginal hysterectomy. These are the steps for vaginal hysterectomy. Now, coming to the complications of the procedure, yes, there are immediate complications, early and late complications. Like immediate complications, yes, there can be risk of infection, risk of bleeding, and slipping of the pedicles can be there. Then infection, bleeding, then risk of DVT, thrombosis, then need for blood transfusion, and then late complications. Sometimes there can be an internal bleeding, return to theatre. Yes, there's a risk of death, which is very less. So these are the complications of the procedure.
Yeah. So you will document everything, right? You will document everything.
Yeah,
and you
everything in the and the post-op care of the patient needs to be.
So well done. Everything you have mentioned everything. Just one point. If you are going for a vaginal hysterectomy or abdominal hysterectomy, and once the patient is under anesthesia, you have to do EUA. Okay, in all cases.
Yes.
That is one thing. So then when we were talking about the indications, so if you will talk about indications, the size of the uterus is less than 10 week size, then all the indications for which we do abdominal hysterectomy, we can do vaginal hysterectomy also, like for myomectomy, right? There is any other, patient has this heavy menstrual bleeding, or she has a prolapse. Okay, these are the most common indications: prolapse, or she has HMB. HMB is basically the most common indication. So we can do that. Okay, so we will consult the patient, and then talking about the complications, just mention a few complications during surgery, in the immediate post-operative period, and then in the long term. In the long term complications, you should mention this post-hysterectomy bond prolapse, and then you should say that perhaps we can take some protective measures to prevent this in the long run. So we can do the sacrospinous fixation, or we can do other procedures, like we can obliterate the pouch of pregnancy as high as possible. So you say like a couple of things so that they will know that you are covering each and everything. So well done. So just remember steps of both types of hysterectomy and cesarean section, because mostly they will ask about hysterectomy. Sometimes they will ask about laparoscopy, but rarely. Mostly they will ask about abdominal or vaginal hysterectomy. Okay, thank you. So next one for Dr. Asma again.
Yes.
Okay, doctor, here is your case. You will just read her history and then you will talk about it. So you will take 2 minutes to prepare your answer and then you will talk about it. Time starts now.
This
You can start,
conference will now
please.
be recorded.
Okay. That's a patient who is 34 years old, and her pap smear showed CIN3. Then I don't know about her. We should do her HPV testing. and then patient should go for colposcopy. The colposcopy we have to do, it is like see and treat. As long she want to start to have a family soon, then we can do the see and treat maneuver. We will do the leads surgery, and then we will send it for the histopathology, and after that we will do a test of cure again after 6 months. 6 months, it will depend on the test. If it is negative, then patient will go for her routine follow-up after, not routine, she will go for follow-up after 3 years again. If she has CIN 1 and 2, then we will go for HPV testing. Then if HPV testing, if it is positive, then it is she will do again this one, colposcopy. If the HPV negative, then she will go for also follow up after 3 years. And patient can, if it is negative, test of cure, if it is negative, then patient can go for her pregnancy, and but there will be a risk of having preterm delivery. So you will counsel the patient that she will need to go for a cervical assessment screening from 12 weeks of the pregnancy. And if she have a short cervix, like less than 2.5 millimeter, then we may go for the option for the cervical cerclage or the vaginal progesterone.
Okay. So, what complications she can have in the long term in addition to these complications? Like you have mentioned, she can have a PPROM, or will it
And
increase her risk of having
preterm
miscarriage?
labor.
Preterm labor. So,
Mm.
can she develop cancer later, or over
Yes,
the next 1 decade or 2 decades?
yes, she can develop cancer in, I'm not sure, I think 1 decade she can develop.
Okay. So, let's say that this patient, you have done laser procedure on her, then she should be in
Mm.
the cervical screening program.
Yes, she will, no, first we will do the test of cure after
Mm-hmm.
6 months, and depend on the result of the test of cure, then she will go for the cervical screening. But the cervical screening, it will not be every, for her age, yes, still she will go for 3 years, but whatever the age, it will be every 3 years.
Okay. Okay, thank you. So, this cervical screening, this is a very tricky area, and the problem here is that we have to recall basic facts. So, first of all, when you have a diagnosis of CIN2 or CIN3, we will not do any testing for high risk HPV. Okay, if your patient has low or borderline dyskaryosis, then you need to
Mm.
do HPV testing. Okay, if they have already CIN2 or 3, they will directly go for
Colposcopy.
colposcopy and then for the further treatment. So when you talk about the colposcopy, then you should mention both techniques that you will do testing with the trichloroacetic acid, or you can use iodine. Okay, if you're using acetic acid, then you will see acetowhite areas. Okay, so since this patient has fertility aspirations, so we can't go for, and this is only CIN, so we will offer her the option of bone biopsy, or we can give her the option of LACE procedure. So LACE procedure is the most widely performed procedure. So once you have offered her this procedure, then what will happen? She can have some complications, like we talked about them, PPROM, or they can have this preterm labor, but more chance of PPROM. There can be cervical insufficiency. So anyone who had this CIN3 and she went for the treatment, then she should come back for the follow-up. So usually first visit is after 6 months. So she underwent this procedure and then she has returned to you. So then we have to see that what should be done for her. So we did colposcopy and we didn't do any HPV test because already severe dyskaryosis. So you did place procedure for her. So what happened? Then it depends that which treatment, that who should come back for test of cure. So treatment of CIN 1, 2 and 3. So all the people who underwent some treatment, they should come back for follow-up, and especially those who had CGIN. So here excision margins, they don't matter with CIN, but excision margins, they should be clear for CGIN, cervical glandular intraepithelial neoplasia. So what is the follow-up? They should come back for the smear at 6 months. So what is done after the smear is taken? Exactly the same as PH. So you are going to see that are there any changes, borderline or mildly dyskaryotic, they will have HPV test. So if the HPV test is negative, they will go back to routine recall. And if it turns out to be positive, like you said, she will go for colposcopy again. Okay. So after treatment of CIN 1, 2 or 3, we will have a smear at 6 months to determine the managements. So here, if everything is normal, send her back for the recall. Otherwise, bring her back for the colposcopy. That is one thing. If your patient had CGIN is more dangerous. So CGIN management is a bit more complicated, and what you have to do, she should attend for the smear at 6 months. Okay. If the smear and the H high risk human papilloma virus test results are negative, then she should come back again after 1 year. It will be 18 months from the time of surgery. So we will do the second test of cure. So if both tests are negative, the one we did 6 months after treatment, and the second we did 18 months after treatment, both are negative, she will go to routine recall. And then according to her age, she will continue going for the follow-up. Okay, that is the thing. Okay. So they will not go into the detail that if CGI has not been excised completely, then what should be done? So if the excision margins are not clear, then some of them, then we have to do the cytology. It is done after 6 months after the treatment, and if it is negative, we will repeat after 6 months. So it will be 12 months after the treatment, and then annually for 9 years. So incomplete excision, then she's going to have this follow up for long periods of time, like that. Then there can be other scenarios where your patient underwent hysterectomy. So after hysterectomy, the follow-up is going to be a bit different. If no CIN and she was on routine recall, we will not offer any follow-up. If in the hysterectomy specimen there is no CIN and she was not on recall, so now the vault is left behind. So we will take smear of the vault at 6 months. And if it is negative, then she will not need any further follow-up. So if she had CIN and it was completely excised, then we will do wart smears at 6 months and then at 18 months. If the patient had CIN and the excision margins were uncertain, but she was on recall, then you can do wart smear at 6 months, then at 12 months, and then at 24 months. If there was incomplete or uncertain excision, and the patient had CIN 2 or 3 and she was on any type of recall, we should do wart smear at 6 months and then 12 months and then long-term follow-up with 9 annual wart smears to 65 years of age or until 10 years after surgery, whichever is later. That's all you need to do for her. So you were justified that you told her about the complications. So you have answered that well. Then another tricky area in cases of cancers can be that they will tell you the same, that the patient is pregnant, but she has cervical cancer and she is at 20 weeks gestation. So what should be done? There is no cervical cancer.
Doctor, you are asking me?
Yes, dear, because you did this
Yeah.
case, Dr. Asma, for
Yeah.
you.
She's now she's pregnant, 20 weeks, and she developed the cancer now. It depends on stage of the pregnancy. If she's already before, if she's reached 28 weeks, then we can terminate the pregnancy after giving steroids, and then we will go for the hysterectomy. Or if it is less than 20 weeks, I think 20 weeks we will terminate this person.
If you will follow the FIGO guidelines, they say that if the period of gestation is less than 20 weeks, then you should offer termination of pregnancy. But if
Less than what, doctor?
less than 20 weeks, 20 weeks is
20.
the
That's
less
why
than
it was confusing. You gave me exactly 20 weeks.
yeah. So she is 20 weeks. If she is 20 weeks or more, you are going to continue the pregnancy. And since she is in the second trimester, so you have to see what is the extent of this cancer. Okay, for clinical staging, she can be started on cisplatin, and once she reaches 28 weeks of gestation, then we can offer her antenatal corticosteroids. Between at 28 weeks, or if she is relatively stable, we can go to 30 weeks, and we will do cesarean, and at the same time we will do hysterectomy. That's how you will manage. If
So
she is less
only
than
if less than 20. If it is 20 or more, then we continue with the pregnancy.
yeah, less than 20, you will just terminate her pregnancy and do hysterectomy. Similarly, they can give you a scenario where the patient had CIN free, she became pregnant, and now they are asking you that can you do this latest procedure or can you do this biopsy? So your answer should be that he can be done during pregnancy, but the problem is patient can have
Risk
severe
of
hemorrhage. But if the
bleeding.
cervix looks particularly bad and suspicious of cancer, in that case, you should refer that patient to the higher center where they will take the specimen, or they can do this. They will take biopsy, cone biopsy, or what biopsy, and then they can pack the cervix. So they will pack the cervix, and she will not have any. Okay, that's the point. Okay, thank you very much.
So, Dr. Aisha,
Thank
at
you.
20 weeks, we will continue. This patient, you asked 20 weeks, we will continue the pregnancy.
Yeah, 20 weeks we will continue. If you will go to gynecological or FIGO, their guidelines, strategy or FIGO, they all say that if less than 20 weeks, terminate and start treatment. If more than this, if 20 weeks or more, then you will give her a chance and you will offer her preterm delivery, and you will give like all the needful, and then you will do cesarean hysterectomy at that time, at the time of birth. That's why I included this book, the third part in the question, because many candidates find it very confusing. That is the problem.
And
But there is
this
medical
one you
evidence
were saying packing, that means the MDT, they can do the LETS procedure in pregnancy.
yeah, they can do the LES procedure in the higher center where and then after the procedure they will they can pack the cervix with gauze, any vasoconstrictors, even cone biopsy they can do that, because if the lesion is limited to the cervix and she has no systemic involvement, and you think that this one looks very bad, in that case you can go for management, but should be done in the secondary care, and they should be ready for the hemorrhage, because patient can have it during they can have it during pregnancy. So that is the point. So basically they will not ask you about anything which is controversial, but now we know that 20 weeks means that you can continue her pregnancy. But if they tell you that now the cancer is disseminating, so then the patient needs treatment, that will be an exception. So you will make a multidisciplinary team to review her and reach some decision. In that case, if this is really invasive cancer, then maybe they will offer termination of pregnancy, and then they will do this hysterectomy. Why? Because cervical cancer, it will progress very rapidly if your patient is immunocompromised. And in regarding pregnancy, we say that this is an immunosuppressive condition. That is the problem.
And this CIN3, it will be preferable to do LETs or cone biopsy. Like
Cone is equally good, but they are always doing less procedure because they are getting better results with that. Like 80% of the surgeons, they will like to do this LASE procedure.
LEDs, because LEDs is more conservative to the cervix. I mean, it will not cut a big portion of the cervix.
Because in cases of cone biopsy, you have to take a wide area. So that's why your patient can have cervical insufficiency. I mean, the depth of the incision will increase in the cone biopsy. So that's why they can have complications later. And when we are talking about the complications like from preterm labor, then you should mention there can be cervical stenosis. So cervical stenosis will have its own problems. Just mention that one also because that is also a result.
So if she has cone biopsy and she comes with pregnancy next time, then we have to do the cerclage.
Yes, we can do, but there is no evidence that it will improve outcome. So it is up to the discretion of the consultant, and then but you will have to do serial measurements of the cervix, and maybe you will have to give her high dose progesterone also. So if the length of the cervix is 5, it is not less than 2.5, then you can support her with high dose progesterone supplementation.
So in its own, it is not indication for cerclage. It's an indication for surveillance of the cervical.
Yes, because the patient is at risk of having preterm labor, T-form, so that's why you need to pay her more attention. And again, you will say high risk pregnancy, concentrated care, constant vigilance, and we can do a serial cervicometry. The length of cervix should be checked, and then we can give high dose progesterone supplementations. You know, they will ask something about cervical cancer because first of all, the incidence is rising. And then recently there were some medical legal issues where the reports issued were not accurate, and several patients, they ended up having cervical cancers. So if you were following news, maybe you have also heard something. Not right now, maybe like 8 or 9 months ago. So, and then this cervical cancer is very popular among the clinicians because there are many controversies on management and on the time of doing this surgery. So that's why. And then the cervical screening can be complicated. Yesterday we did one station on vaccination. Okay, so
they will ask for the staging also.
Yeah, so no, if this patient already has CIN3, so no benefit.
I mean, if the cervical cancer, any scenario about cervical cancer, about staging.
So revise the basic information on the cancers. Okay, can be ovarian, can be endometrial. So endometrial, usually they will not ask, they will just give you heavy menstrual bleeding, and then they will ask you what is the possibility that there will be endometrial cancer. So anyone who is coming to you with heavy menstrual bleeding, you should remember that 10% they can have cancer at the same time. That's why histoscopy and biopsy is very important before going for hysterectomy. That is the point. Okay. Any other question? Any problem?
CIN3, how many progress to cancer, Dr. Aisha? It is, I think, 10 to 15%. I don't remember.
Yeah, 5 to 10%. 5%. That is the maximum. 5%. Before that, hardly 1%. CIN1 less than 1%. And that too over a period of 20 years. And basically, you know, once you have cleaned the lesion, Then the patient the host, the one who is a patient, her defensive mechanisms, they will come into play. Okay. And since they have a role, she will not progress and maybe it will be cleared. So as you can see that 95% patients, their immune system is intact, then they will not proceed to cancer. And just 5% they can develop cancer, but that too over a period of 20 years.
Doctora, for the staging, we will follow the old FIGO or the recent one? The 2018 one or the previous one?
So, sorry, I didn't get you. You are asking about the cervical
About the
screening for
stage
her or what?
FIGO. No, about
Yeah, yeah, yeah.
FIGO staging, we
Yeah,
will follow the new recent one, 2018 FIGO or the previous one. Because they said
2018.
2018 is not being used yet in UK.
Okay, but I will tell you one thing.
Mm,
They will never ask you about the classification of that grading or staging. They will just tell you that patient has this condition, so what should be done for her. Because if she's already in stage 3 or stage 4, you are going to give her only palliative treatment, right?
palliative.
So they will give
Mm,
you stage 1 or stage 2, where mostly stage 1 if they want you to do further management. Because no point in asking about stage 3 or 4, because that first of all that those patients they will receive care in oncology units, right? They will have a multidisciplinary team and they are going to treat the symptoms of pain, constipation, lack of appetite, cachexia. Due to this malnutrition, patient can develop other infections and problems. So we have to deal with these three parts and then the stress, because they know they are going to die, so they can be under tremendous stress. So they will need psychological input. Only four things. So you cannot talk a lot about grade 3 or grade 4 cancers. Just palliative treatment, radiotherapy or chemotherapy, or you can combine both modalities. You should just remember a couple of things, that if they give you a patient who has a cervical cancer or has this vulval cancer or endometrial cancer, so even if she is in grade 1 stage 1 or in the advanced stage, so but they are unfit to tolerate surgery, then you can offer radiotherapy as the primary treatment in all three cancers. You cannot offer radiotherapy as primary treatment if your patient has an ovarian cancer, because in ovarian cancer you have to do a staging laparotomy and everything, okay, because that is diagnosed usually in the third stage. But all other cancers, they can be diagnosed in first stage. If they are fit and well, you will go for surgery. But if they are unfit, then you can offer them primary radiotherapy. Okay, any other question, any problem?
thank you.
So we need the basics of oncology, like basic steps, not in detail.
Not in detail. You can do screening for the ovarian cancer, right? But we cannot, and you can do screening for cervical cancer, right? But for the ovarian cancer, you're not screening everyone, right? Because we don't have, if they have any high risk or they are symptomatic only, then we will follow them up. Or if they have family history of hereditary cancer syndromes. So, they will not go to the advanced level. Once you diagnose the patient, then your job ends. Or if you can identify risk factors, that is also your job, but not beyond that. After that, that is job of the onco specialist. Your job will end once you will refer your patient. So don't worry, oncology is not very heavily tested. Maybe just one question in a while. Once they asked about endometrial cancer and cervical. Once they asked about cervical cancer, and then once they got this ovarian cancer, someone was in stage 3, so you had to do counseling for her, endometrial. So cervical is more popular because it can affect, the younger people also. Even the vulval can affect, but the vulval cancer is very rare. That's so you should know about the ovarian cysts in the premenopausal and postmenopausal woman, just the basic facts. Endometrial hyperplasia, just do one page from the guideline, Green Top guideline number 67. So actually you have to study smart. Don't try to read each and everything. Now it seems like you have 1 full month in your hand, but this time passes very quickly. So don't try to read each and everything, just the main points. But history taking both in gynae and obs, that should be very good, because this Irish exam, because if it's long case, it depends on your performance there. So try to take a good history, because you will make a good impression on your examiner also. So anything comes to your mind, just ask me, okay? Don't worry. Even you can write in that book. Don't worry at all. Okay, Dr. Rehan, next case is for you. You will take 2 minutes, then we will talk about it.
Okay.
This conference will now be recorded.
Okay.
Hello. Yes, I'm Dr. Faria, one of the exam candidate, and I'm ready for the structured discussion.
Okay, welcome. So if you have a 29-year-old woman with twin pregnancy of 12 weeks, how will you do antenatal care for this patient?
Yes, twin pregnancy, basically it is a high risk pregnancy, and it is high risk for both mother and the babies. So she should be referred to a consultant led unit, and we should make sure that there is a special baby care unit also available in that hospital. And as she is at 12 weeks gestation, so we can offer her, first of all we have to ask her the signs and symptoms of pregnancy, because in twin pregnancy there can be she can have excessive vomiting and nausea. So we have to check her dehydration and rule out hyperemesis gravidarum, and then we have to offer her dating scan, and if not done. And then we also have to offer her Down syndrome screening, which can be offered from 11 to 13 plus 6 weeks. And basically we have to, these as twin pregnancies are higher risk, so we have to make out the, to determine the chorionicity, and it is ideally done at 14 weeks. And it should be done by a specialist sonographer who should write determine the gestational age, chorionicity, and at the same time they can perform the NT scan as well, and they have to mention that how many placental masses are there, and they also have to mention whether the twins are monochorionic or dichorionic, and they have to label the twins, that which one is the twin 1 and which is the twin 2. So if it is not possible in the first scan, then they have to offer them a second scan by the specialist, and but it should be there should be a photographic record in the notes as well.
Yeah.
And
So
sometimes there may be little, one twin may be little bigger than the second twin, so they will then take the gestational age according to the size of the bigger twin.
Yeah. So how frequently they need to do this ultrasound scanning?
Yeah, these patients, they usually, if they are dichorionic diamniotic, then they should do the ultrasound scanning from 20 weeks of pregnancy, and they should do every 4 weeks till 36 weeks. And if monochorionic twins, then they have to start scanning from the 16 weeks of gestation, and that will be every 2 weeks till 36 weeks. And basically the aim is to pick up twin to twin transfusion syndrome and the risk of selective fetal growth restriction.
Okay.
So if there is
So,
any complication, then they have to refer them to the fetal medicine unit.
so do you expect any medical complications if the mother has a twin pregnancy?
Yeah, in twin pregnancy, there is a risk that patient can have anemia. So we have to offer her full blood count and red cell antibody screen at 20, 24 weeks and 28 weeks of gestation. And also they can be at increased risk of preterm delivery. So we have to educate the patient regarding the warning signs, that if she has any pain, any discharge, or then she has to report immediately to the hospital. and also they have to there's an increased risk of preeclampsia. So we have to start them on low dose aspirin from 12 weeks of gestation, and to continue till 36 weeks of gestation. And also they are at risk of anemia, so we have to give them folic acid and supplements, iron supplements. And then there is an increased risk of gestational diabetes, and also there is an increased risk of venous thromboembolism in the twin pregnancies.
Okay, so will you like to do OGTT for this patient?
Yeah, I will do OGTT because she will be at high risk of gestational diabetes.
Okay. So do you think we need to do serial growth scans for her?
Yeah, we need to do serial growth scans if because we don't know now that it is dichorionic diamniotic, but for both type of pregnancies we have to do the serial growth scans.
Okay, so when we should decide about time of delivery? When the decision should be finalized?
Yeah, we should offer them appointment with the multidisciplinary team at 36 weeks of gestation, and we should decide for the timing of delivery. Most of the twins, they deliver preterm, but there should be a documented care plan in the notes, and we can offer the delivery at 37 weeks for dichorionic, diamniotic, uncomplicated twin pregnancies. And we should tell them that there is an increased risk of fetal death beyond 38 weeks of gestation. So we will offer them a course of steroids, and then we will recommend them elective birth from 37 plus 0 weeks for dichorionic uncomplicated twin pregnancies. And if monochorionic monoamniotic twins, then we have to offer them delivery at 34 to 36 weeks of gestation, because there is an increased risk of complications in monochorionic twins.
Okay. So how will you plan her delivery?
Her delivery
I
will
mean,
be planned under the care of multidisciplinary team in the consultant-led unit with the facility of availability of special care baby unit. And at the time of delivery, if she has not gone into labor, then we can offer them induction of labor. And we will see the presentation of the twins. If the first twin is cephalic, then they can have normal vaginal delivery. But if the first twin is breech, then we will offer them a cesarean section. And if during the delivery, the senior obstetrician should be present, and at the time of labor, the patient should be there should be ultrasound in the labor room. And when the first twin can be delivered in a routine way if it is cephalic. And then for the second twin, we should have assistant available in the labor room, and there should be 2 pediatrician available, specialist midwife should be there, consultant obstetrician should be informed, and ultrasound should be there. Then first twin is delivered, then we have to stabilize the lie of the second twin, and we can do external cephalic version to guide the head into the pelvis. And when the head is guided into the pelvis and it is stabilized, then we can do amniotomy. And usually we are not giving syntocinon infusion for the first twin, but for the second twin we are keeping it ready. And if the patient is not contracting well, then we can give syntocinon infusion, and then head is settled, we can do amniotomy. If external cephalic version fails, then we can offer them internal protallic version. First of all, we will keep the membranes intact and attempt internal protallic version through the membranes. If it is not possible, then we can rule out cord presentation, and then if there is no cord and there is no risk, then we can do the membrane rupture and internal protallic version, and we can deliver the baby as breech, second twin as breech. And there is a risk of postpartum hemorrhage, so we will do the active management of the third stage of labor. Both babies will be handed over to the pediatrician, and patient should be given syntocinon 5 units IV, IM 10 units IM intramuscular at the time of delivery of the anterior shoulder. And this one, sorry, we will give for the first, we will give after the delivery of the second twin, at the delivery of the second twin, uterotonics. And after the patient is delivered, then we will maintain her, we will watch her for postpartum hemorrhage, and we will provide IV hydration, analgesia, and then we will document in the notes and debrief the mother. In case of postpartum hemorrhage more than 1.5 liter, or if there is APGAR score less than 7 for any of the babies, then we can do the incident report. For monochorionic, monoamniotic twins, usually we are offering them delivery by cesarean section at 32 to 34 weeks. And because there is a high risk of cord entanglement, and there are multiple risks involved with the monochorionic twins. Monochorionic diamniotic, they can be offered delivery around 35 to 36 weeks of gestation. 36 weeks of gestation after the administration of corticosteroids, and they can have vaginal birth if the first twin is cephalic.
Yeah, that's correct. Okay, thank you. And delivery should be attended by the neonatologist, and we should identify the cords appropriately. Okay, so
Yeah,
well
they
done.
should be the cord should be tagged, or they should be labeled that this is twin 1, this is twin 2,
Yes, they should be labeled. That is important.
and they are high risk of thrombosis, so we should assess for venous thrombosis after the delivery, and give them dead stockings or low molecular weight heparin according to their risk. And if RH negative, then we have to offer them RH NTD.
Yes, that's great. So, when you were starting this station, I was hoping that you will ask me that this patient has a, this spontaneous pregnancy, or she has assisted reproduction. So, if
Yeah.
right from this question, it will be very clear for you that you are dealing with monochorionic diamniotic or dichorionic diamniotic pregnancy. Okay, sometimes they will hold back. Usually, they will give you full information, but sometimes they will hold it back because they want you to comment on that. They want you to ask them because it's not possible to describe all different types of twin deliveries within 10 minutes. Okay,
So
so
we
always
when we
ask.
ask, if they say IVF, then that means it will be most likely monochorionic diamniotic.
IVF means dichorionic diamniotic because
Dichorionic
they
diamniotic.
use
Okay.
two embryos, right? They will put two embryos.
Okay. Okay.
That is the point. Okay. So even if they will put one embryo, it can develop into two, and then there can be twin pregnancy, but that will be maybe 1 in 100 million, like that. Okay, that is the point. So because they will have this instruction that once the candidate asks you, then give her this information. That's why you should ask from the start, so it will make things clear for you.
So
So
in
you are
spontaneous,
mentioning,
monochorionic risk is more in spontaneous
yeah,
pregnancy.
yeah, monochorionic and diamniotic. That is the commonest variety if the patient
Hmm.
has spontaneous pregnancy.
Okay.
Monochorionic diamniotic.
I had no idea of this point. I never.
Uh,
Me too.
I
But
think
also, يعني spontaneous pregnancy can also be both, يعني mono or di
that can
or
be both. Of
yeah.
course, can be both, but 35%, but almost 50% will be monochorionic diamniotic.
Mm.
Okay,
Okay.
can be, especially if the age of the mother is increasing, then
Mm.
there can be monozygotic twinning or there can be dizygotic twin pregnancy also. That is the point. But mostly that will be monozygotic because the this zygote divided in the early stage. So Dr.
Uh,
Priya mentioned everything. Yeah.
They
Yes.
one
can
more
ask
thing.
us the complications also, TTTS, and like classification of
Yeah.
TTTS and like this.
Yes.
They can
If
be
you
asked.
say typical, yeah, they can ask you, but they will not ask you
Mm.
directly. They will ask you
Mm.
indirectly, like how you are caring for them. So you know that in case of pregnancy, we have to do fortnightly ultrasound because we are looking for that
Detect
detecting
it.
this quick transfusion syndrome. That is the reason. Okay?
Mm.
That's why we will start and we will continue. And we can stop this by the fortnightly ultrasounds once she reaches 24 weeks. After that, offer OGTT, then growth scans, because in twins, all complications are going to be much more common. IUGR, preterm love, birth and delivery, PPROM, then there can be abruption, there can be placenta previa, and there, then what else can be there? Can be sudden IUFT, then demise of one twin. So that's why we have to be careful. So both scans will be done every 4 weeks, but when it comes to seeing the frequency of examinations, you can call them every 2 weeks. From the second trimester till the end, they can come to you every 2 weeks. Similarly, if you have a patient with hypertension or diabetes, then again, you don't have to ask them that they can come once a month. As the nice guidance says, that you can see them every 1 to 2 weeks, depending upon the severity of their condition.
Both type of twins.
In twins, you will see them every 2 weeks in all
Okay.
types of twins. Okay.
All types. Okay.
If your patient has PET, essential hypertension, or diabetes, then you should see them every 1 to 2 weeks, because such pregnancies are very complicated. So if the patient is doing well, then maybe you can call her after 2 weeks, but you will not tell her to come every 3 weeks or every 4 weeks.
Okay.
So more frequent visits if your patient has some serious medical disorder. That is the point. Okay, so Dr.
And
Priya mentioned our point. Yeah,
why
yeah, you say.
postpartum their more risk of thrombosis?
Because they can have this one. They can have PPH at the time of birth. That is also one of the risk factors. So, and then, we will not say that the thrombotic factors are higher, but it has
Yeah,
been
because
from the
as
study.
I know, it's a risk factor during the pregnancy itself, not
Yes, yeah.
not after the
During
delivery.
Yeah, during pregnancy, the risk is higher because the blood flow is even more sluggish because the uterus is very large. So in the post-op period, you will follow the same risk factor, this guideline, the green top guidelines
Yeah,
number
yeah.
27A and B.
Mm,
And if she has two risk factors, you will start treatment for her.
10 days.
That
Yeah.
is the point. Before that, for all such women, what you can do is you will offer TED stockings to them. You will offer them early mobilization and good hydration. That's how everything is going to be fine. So, do you have any other question?
No, so thank you.
So briefly, we will go over this one because this one is helpful. That a suggested protocol for vaginal delivery of twins. That you should top up epidural site IV infusion. In the low risk women, we are not citing IV, but in cases of twins, since we can have more complications during labor and in the postpartum period in the form of PPH. So we will keep syntocinon ready for second stage and we will give IV infusion. So you will deliver first twin as you will deliver any single baby and ask someone to write down the time. Then if you can see the lie of the baby and you can detect fetal heart, that's good for the second baby. Otherwise, you will take help of portable ultrasound to see the lie of the other or second baby. So start CTG of the second twin and write down the time when you have started CTG for her. So here the baby can be in cephalic presentation or non-cephalic. If non-cephalic, so it can be transverse or it can be like in a breech presentation. So let's say that if the baby is in a transverse lie, then what you can do, even for the transverse lie, for the breech, for both, you can offer external cephalic version as the first step. So if it was successful, then you will do ARM and if there is any fetal distress or any delay, ideally the gap between the delivery interval between delivery of the first and the second twin should not be longer than 30 minutes. So if there is any evidence of fetal distress or delay in the second stage of labor, then you can use ventools, okay, or you can deliver them. If you don't suspect any fetal distress or delay, then you can allow that for normal delivery. So if you try to do baby was transverse and you tried to do external cephalic version and it turned out to be unsuccessful, then you will perform internal podalic version through intact membranes, okay, and you can take the baby like this and you can deliver as a breech. So twin breech delivery is not difficult because the babies are small. Then you should offer active management of third stage of labor. So give 10 international oxytocin with delivery of the shoulder of this second baby, and after that run syntocinon infusion over a period of 4 hours, 40 units syntocinon in 500 cc normal saline or hard bed solution. So that's how you're going to care for them. So with that, we have finished 7 stations, one circuit. So now you can have a break for uh, 30 minutes if you want to pray and you want to take your food. And after that, please come back. We will do another circuit. Thank you.
Thank you, Doctor.
Doctor.
Sorry, Dr. Aisha.